Thank you. Thank you, Alexis. Good afternoon, everyone. I really appreciate this opportunity to talk with you about some basic aspects. Let's see if yeah, some basic aspects on this disease, the Rocky Mountain spotted fever, that most of you know is a public health problem and a medical threat in many countries across the Americas, including the United States. So I want to thank to the NCFH. I'm very excited for having this opportunity. To my colleagues in CDC by their valuable feedback, and of course to all of you. I will try my best speaking in English, and please excuse me for my mistakes in doing so. Um, um, as a disclosure, I do not have any conflict of interest for this talk that I prepared with the aim to review with healthcare workers, uh, medical students, and other researchers some basic clinical and epidemiological features about Rocky Mountain Spotted Fever, RMSF. Uh, we are going to start by highlighting four fundamentals about RMSF, which, by the way, has recently increased in the US-Mexico border, a region where higher case fatality rates than the expected have been observed. So the following characteristics are key to all of us. Number one, we need to be conscious that it is endemic to several regions across the Americas. Cases and deaths are annually reported. Uh, Number two, it is difficult to diagnose it because its early clinical characteristics are quite similar to many infectious diseases. Number three, this disease, if not timely treated, shows a high proportion of severity and fatal outcomes in the ill. And number four, despite of that, we have a specific and highly efficacious antibiotic to deal with the pathogen, doxycycline, when properly prescribed. As background, most of you know that RMSF is an infectious disease, a zoonotic infectious disease, usually transmitted from animals to humans through the bite of hard ticks within the Ixodida family from different genera, such as Dermacentor, as you can see, and Rhipicephalus ticks. RMSF can provoke a really high rate of fatalities among people who is infected by rickettsia, the pathogen, the agent of this disease. Let's talk about a little bit about some ecological and epidemiological determinants that I'm sure can help us to identify people at risk of getting the infection. So this review is to with the aim to understanding who is at risk. Overall, we need to be sure that RMSF has a very complex transmission cycle that can involve different host vertebrates, most of them mammals, either wild or domestic. Among them, the most common are deer, opossum, many different types of rodents, coyotes, capybaras, and very importantly, in some regions or countries, domestic dogs. It is important, very important to know that at least 10 different species of the Ixodia ticks can transmit Rickettsia rickettsii to humans. This pathogen is released into the bite site within a few hours after attachment. Afterwards, an incubation period following tick bite is roughly a week in most patients, although can range this incubation period from 2 to 14 days. Um, the disease, RMSF, was first described, in the Bitterroot Valley in the late 19th and early 20th centuries. There exist several excellent historical references that you can consult to get a deeper understanding on the clinical, epidemiological, and microbiological aspects of the disease. But in Mexico, soon at the beginning of the 20th century, deadly outbreaks of the disease were described, particularly in the northern region of Mexico, with cases and fatal cases occurring across the countries for almost 5 decades before this disease disappeared suddenly in the 50s. The disease can occur in a variety of settings that includes forests, deserts, mountains, wetlands, and in these scenarios, a myriad of social and environmental determinants can sustain its transmission either in urban, suburban, or rural settings. A variety of conditions such as temperature, humidity, and very important, the availability of hosts are crucial for the abundance of the ticks, and so to the likelihood to be exposed to the pathogen. Ecologically speaking, we can agree that RMSF epidemiology largely depends on regional characteristics. For instance, in the US, the dermacentor species ticks are the main vector, while in Mexico and other Latin American countries, in South America particularly, Rhipicephalus sanguineus sensulatus play a major role. Um, Furthermore, we can approach RMSF from a different perspective than the traditional one, under a different perspective. If we use a social perspective, we can give an importance to the role played by the social determinants of health. As has been observed in some communities in the southwest of the US and Mexico. In these regions, social disadvantage and poverty are associated with a higher risk of infection and fatal outcomes in the ill. Very interesting in several regions of the Americas. It has been recently observed an increase in the presence of RMSF associated with the brown dog tick, Rhipicephalus sanguineus sensulatus. This vector is very interesting. It has a very interesting ecological characteristics because shows capacities to survive in different environmental conditions. And very importantly, it has great capacity to adapt to live in and outdoors. Other remarkable characteristic of this tick is its preference to feed from domestic dogs. This tick is almost active year-round. As I mentioned, the disease is not known in other continents different than the Americas. It's exclusively distributed in the Western Hemisphere, from the US up to the south of the Americas. The three countries with a major burden of the disease are the US, Mexico, and Brazil. For instance, in the US, the annual incidence of is roughly 3 cases per 1 million of inhabitants, with some states showing rates above 4 cases per million of inhabitants. Really particular pattern of the epidemiological pattern of the disease has been observed in Mexico. Mexico has shown an increase in RMSF morbidity and mortality as well, particularly and very noticeable in the northern Mexico, where the incidence and the mortality is quite far from the other regions in Mexico. In this region, in the northern part of Mexico, the northern region of Mexico, there is a high incidence of over 20 cases per 1 million inhabitants. That means that it's at least 6 times higher than the US national rate. And in this region, we have a really high rate of fatalities. And when I say high rate of fatalities, I'm speaking about 30% of CFR. This fatality rate is impacting vulnerable populations and communities. Epidemiologically speaking, these regions show an hyperendemic profile with outbreaks. I mean, this is the region that I'm talking about, with outbreaks in the largest urban cities within the north of the country. And very important for physicians and health staff, healthcare workers in both sides of the border region. A very similar pattern of the disease has been observed since early 2000 in some rural communities of Arizona, where peridomestic ecology and risk factors are the same or quite similar to has been observed in the current urban outbreaks occurring in Mexico. This has been documented from early 2000 that it is very parallel to what happened in Sonora at the early 2000. So the epidemiological pattern in both in Arizona and Sonora are coupled in time and in ecology and social factors related with the emergence of the disease. In almost 2 decades, from the early 2000 up to the current days, The spread of RMSF outbreaks in northern Mexico, but I would say that in other states in Mexico, has shifted from being in or appearing in rural communities with isolated cases and familial clusters to hyperendemic foci in large urban centers. In this slide, I'm giving you two examples. The situation or the outbreaks in Mexicali in Baja California and the spread of the outbreaks at the county level in Sonora, Mexico, both in northwestern part of the country. Such epidemiological pattern and spread should be a cause for concern for healthcare workers, clinicians, and doctors in both countries, especially those working in the border region or as you with familiar with or related to the care of farm workers. Why? Because recent scientific evidence have described the occurrence of RMSF binational cases, meaning that they can acquire infection in a specific endemic region, for instance, in Mexico, and become ill in another, as has been observed, for instance, in the cases of uh, California and Arizona, where patients have been identified being infected in some Mexican states and getting ill in the illness in or become ill in the US. So this could be a really mm, important matter for practitioners in both sides of the countries. All of us know that the US-Mexico border region is characterized by an intense exchange of assets and services, as well as a remarkable population mobility, where we think there is a high potential for patients seeking care for RMSF at or near the border. So we could ask who is at risk? What kind of person is at risk of getting the infections? And in this situation, we know that at individual level, biological determinants play a crucial role in the disease pathophysiology and outcomes. Among the most important risk factors that we can have observed in almost 2 decades, they are the following. Children less than 10 years old and adults more than 15 years old, males, and some chronic conditions, particularly alcoholism or patients with type 2 diabetes. And finally, some patients or persons with CGPD deficiency are at the higher risk of progressing to severity and fatal outcomes. Uh, at the population level, we have a different perspective. We could, of course, it's a really complex disease involving a lot of determinants. But maybe in some regions, as I mentioned, in both sides, especially in the southwest of the US and in Mexico, we should carefully consider other determinants. when we talk about RMSF, associated specifically to the brown dog tick, an approach focusing on social determinants that be very helpful. For instance, in our country, in Mexico, the disease has a deleterious effect on poor people that dealing with a variety of difficulties. For instance, they usually have barriers to access to healthcare and prevention. They face poor housing, uh, poor housing conditions. They usually are unprotected or have unprotected exposures to ticks, and they have a very reduced and very poor, very limited risk perception, uh, not only among the community, but as well within or in health uh, care workers. So these are a wide range of determinants at the population level play a really important role to explain the epidemiological profile we see in some regions in Mexico and the potential that can occur in some other areas of the US. Now, I would like to talk with you about some of the most clinically relevant features of this uh, very horrific disease, the Rocky Mountain spotted fever. Uh, I will start saying that in general, RMSF represents a challenge for physicians because its early symptoms mimic a wide range of acute infectious diseases, uh, such as arboviral infections like dengue, but as well some respiratory illness like COVID-19 or other endemic conditions in Latin American countries like leptospirosis or so. And very important, recently we in both countries, in the US and Mexico, uh, we have these outbreaks of measles. So now measles is another condition that may we need to take into account very carefully to distinguish from RMSF. So I briefly, I would explain or I would talk with you a little bit about some pathophysiological events related with the highly virulence that shows the pathogen. As I previously stated, rickettsia is a very high virulent pathogen, meaning that a high proportion of the ill will develop severe outcomes. The underlying pathophysiological events are complex, but we could underscore that rickettsia severely damage the plasma membrane of endothelial cells and disrupts the structural organization of intracellular organelles and the cytoskeleton. In this sense, oxidative injury to host cells provokes to diffuse microvascular injury and fluid leakage into extravascular spaces. So the damage to the endothelium, which is the key damage, the more important damage provoked by the infection, the damage to the endothelium of the dermis, the skeletal muscle, and vital organs such as the brain, heart, lungs, kidneys, and gastrointestinal tract results in the systemic manifestations observed in patients with RMSF. So we have the rickettsial vasculitis as a very severe process that causes not only an altered vascular permeability, but also is coupled with inflammation and vascular dysfunction. So in addition to the endothelial damage, that is the main or the primary outcome of the rickettsial action. Another relevant pathological feature of RMSF is the increased vascular permeability, which alongside occurs with an intense inflammatory phenomenon mediated by cytokines and an increase of improcoagulatory phenomena. The increase in vascular permeability provokes severe manifestations such as you can see edema, low blood pressure, hypovolemia, organ hypoperfusion, respiratory distress, and central nervous system abnormalities. Although there are multiple manifestations of RMSF's clinical severity, four stand out. Number one, respiratory failure, encephalitis, hypertensive shock, and acute renal failure, which explains and you can understand the reasons of the difficulty in managing critically ill patients. Um, so, with this in mind, understanding the onset of the disease is key to prevent serious and fatal outcomes. As you know, RMSF usually will start as a non-specific group of symptoms, a mild group of specifics or non-specific symptoms, I would say. Malaise, chills, high fever, and myoarthralgias are among the most frequent of those symptoms. Those symptoms are usually sufficient for the patients to seek care. That this is very important. Uh, to seek medical attention within the first 42 hours of onset. So we have enough time to suspect of the disease. So at this time, suspicion of RMSA at this beginning, a clinical beginning, is crucial. One of the main symptoms that are described and actually gives the name of the disease is the rash. Uh, let's talk a little bit about the rash. At first, uh, this rash, it is very important to be sure about it. It's very difficult and or cannot be distinguished from other exanthematic diseases. In this picture, you can see patients with the early symptoms, with early rash, and you can observe that they are very similar. They resemble to other exanthematic diseases. The rash, it is usually small and spreads centripetally. It is important, very important to know that between 20 to 30% of patients with RMSF do not develop a rash. Uh, and even it is difficult to detect in dark-skinned patients. So we need to have this in mind in order to not to fail to suspect of the disease. Uh, I want to show you now the typical expression of the rash in the early phase of the disease. When we are going to talk about the early phase, usually we are going to talk about the first 2 to 4 days from onset of symptoms. And in these pictures that corresponds to pediatric patients, you can see that the rash is very atypical. It's very common to other exanthematic diseases. So for a clinician, it's really hard to distinguish from other diseases. And, however, in the late stage, and when I say late stage, it's not a late stage. We are talking about the fifth day and beyond from the onset of symptoms. So it's not a long period of time. But in this phase, in the RMSF late stage, which, as I said, goes from the fifth day and beyond from onset of symptoms. The endothelial damage that I said is the key pathophysiological damage. Can produce skin lesions, as you can see in this slide. You can see the petechial rash that usually appears and produces a very characteristic sign of the disease. The petechial rash involving palms and soles, a manifestation of delayed diagnosis, and often, and sadly, associated with a bad prognosis. Other late clinical signs of RMSF include periorbital edema and swelling of the hands and ankles. And as you can see in these pictures that are in hospitalized pediatric patients. The progress of the disease is quite dramatic. You can see these pictures of patients that with the disease. As RMSF progresses, the rash becomes petechial, and the individual lesions frequently coalesce to form large ecchymotic plaques. You will observe these lesions in the following slides. In this stage, you can imagine the critical condition in the patient is pretty obvious. That kind of lesions that the name to spotted fever to the disease, no, with uh, generalized exanthematic lesions, petechial exanthematic lesion in thorax, abdomen, arms, and so. So the patients in this phase are quiet. They have quite very severe forms of the disease. Um, uh, this is why the disease take the name of spotted fever in patients that are in the late stage of the disease. A, a proportion, I would say that around, if not treated timely, a proportion of critical patients can develop gangrene and necrosis. This stage, as is pretty obvious, is coupled with severe systemic manifestations, anticipating fatal outcomes. So, uh, trying to put all this data uh, together, we could approach RMSF clinics as a roadmap. I want to propose to approach this symptomatology as a roadmap, having two stages. The first, the early stage, and as I would say, as I said, it goes from the beginning to up to the 4th day of clinical progress. Last 1 to 4 days after exposure to an infected tick. This phase is clinically, of course, non-specific and resembles to many infectious diseases. Therefore, here in this stage, empirical suspicion and timely prescription of doxycycline are essential to prevent disease progressions. We have a really small time window to be active in managing correctly to our patients. In this early stage is that phase. In the following the roadmap, as the disease progresses, the latest stage that lasts from the 5th day and thereafter corresponds to the critical and severe manifestations, including edema, petechial rash, respiratory distress, and neurological manifestations. Some alterations in laboratory biomarkers. Of course, they are not non-specific to the disease or for this disease, can be observed, such as decrease in the platelet count, hypoalbuminemia, and hyponatremia as well. When patient worsens, the rash coalesces, as I said, to form ecchymosis, and necrosis can be seen in appendages. Death can rapidly occur because of multi-organ failure and septic shock. And when I say rapid, I'm talking in about less than 10 days. In our experience in Mexico, the death can occur in average in between the 7th and the 9th day from clinical onset. So it's a disease not only dramatic but rapid as well in the final outcome. So with these proposals of approaching the disease as a roadmap, and with this clinical background, maybe we are able to understand why it's so important to suspect the disease at the earliest stage. To do so, I all the time say to my medical students, it's important to suspect the disease at the earliest stage. So, but to achieve that, clinical skills should be complemented with epidemiological clues, intentionally looking for history of tick exposure, with looking intentionally for recent contact with animals, especially those that could be infested, and very important in some regions across the border, where contact with free roaming dogs. So these search for epidemiological clues can save lives and can help clinicians to correctly suspect of the disease. So, in my opinion, in my perspective, an early suspicion of this disease may be achieved if we incorporate 3 key concepts. Number 1, we need clinics and epidemiology altogether in order to distinguish RMSF from other infectious diseases. Number two, most of patients come to see us with non-specific symptomatology. So our knowledge and awareness about the disease are fundamental to suspect the diagnosis. And number three, RMSF always will challenge us because mimics other endemic febrile diseases. On the other hand, let's talk a little bit about laboratory characteristics of the disease. Generally speaking, RMSF does not have any typical laboratory features, particularly in the early stage when we can see outpatients. However, some common characteristics can occur after the fifth day of clinical progress. Um, that uh, characteristics are not non-specific of the disease, but they are common. Um, I made a review of some of our scientific papers on that have talked about the laboratory characteristics, and I can summarize the following as the most common or relevant for RMSF. Thrombocytopenia, hyponatremia, and hypoalbuminemia are among the most frequently observed in hospitalized patients that usually are in a hospital after the fifth day of clinical progress. Other biomarkers are alterations in liver um, and muscle enzymes like the creatine kinase. And we have, our patients have usually normal white blood cells. This is the pattern, the more common pattern at the biomarker level that we can observe in patients that are hospitalized by this disease. So, as I mentioned, the we in this proportion of patients that are hospitalized, we could say that a low count of platelets, serum sodium, low serum sodium, and hypoalbuminemia are common in RMSF hospitalized patients because they share very they share some pathophysiological mechanisms that explains the not only the damage to the endothelium but the alterations into the vascular permeability. But I would insist that these biomarkers, these clinical biomarkers, if while they are common in hospitalized patients, they are usually absent in the early stage. So very rare, we will find them in our patients. So we uh, do not have to, 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 to rule out the suspicion because a patient they don't have these biomarkers in a blood sample. I will insist that RMSF challenges clinicians with when only symptoms but no epidemiological clues are considered. As you can observe in this chart, a myriad of diseases should be included in the differential diagnosis of the disease. While most of those diseases are infectious, some others should also be considered very carefully. In my experience, in our experience, we have seen patients with acute abdomen produced by acute appendicitis or heart disease, or even by ITP, by idiopathic thrombocytopenic purpura, be confounded with RMSF. So we need to be very, very careful when making a differential diagnosis of the disease. And in this chart, I prepare kind of, the more common, the most frequently reported in scientific literature. And you can observe there are a lot of diseases. Most of them infectious, of course, but we also need to be careful of about other clinical conditions. In the following slides, I will share some specific clues or characteristics to distinguish RMSF from other exanthematic diseases that can be considered the most common to compare with RMSF. For instance, in Latin America, I would say in Mexico and other countries, for instance, in Brazil or Colombia, arboviral infections, particularly dengue, Zika, and chikungunya, are among the most relevant. The rash in these diseases are very peculiar, characterized by redness. The patients have pruritus, which is not common in patients with RMSF. And other clinical characteristics include retroorbital headache, severe myalgias, and leukopenia. Other diseases that are clinicians want good like to include in their repertoire to distinguish RMSF includes enteroviral infections. This disease can produce this kind of exanthematic lesions, and currently we need to consider very carefully the potential for measles. Although, as you know, measles usually are accompanied, coupled with respiratory symptoms. But the rash is typically begins on the head and face, which is very different that is happening with RMSF. That, as I mentioned, it starts usually in wrist and ankles, and other very characteristic symptom in measles is the presence of enanthema, which is a prodromal symptom. Thank you, Alexis. I'm gonna finish right now. ITP and other rickettsiosis, including typhus and infections by Rickettsia parkeri, also need to be considered. Clinicians face a challenge to confirm rickettsia infection. This pathogen is elusive to laboratory techniques. Because of that, it is important to emphasize that the etiological confirmation targets epidemiological purposes, but not to guide clinical decisions. Overall, we have 4 alternatives. Number 1, the detection of IgG antibodies through indirect immunofluorescence, IFA or ELISA assays, which is the gold standard, although difficult to achieve because in a proportion of patients, because we need to prove a fourfold increase in the IgG titers in paired serum samples run between the 2nd and the 4th week. So practically, it's really hard to get in a high proportion of patients, especially in those who develop severe symptomatology. The second alternative, and it's increasing its helpfulness, is the molecular biology, particularly the polymerase chain reaction, immunohistochemical and immunofluorescence staining of rickettsial antigens, and finally, culture of the bacteria in specialized laboratories. Very important to take into account this. A negative result during the first few days of illness should not be used either to exclude the diagnosis or to delay the specific treatment. So let's talk a little bit about the RMSF specific treatment. All patients with suspicion of the disease should receive a specific treatment with antibiotic. The elected drug for almost all cases is doxycycline, which is highly effective and can prevent progression of the disease to a severity and fatal outcome. I would give you three key messages. Number one, doxycycline should be started as early as possible. A delay in the prescription of the antibiotic is associated with a higher risk of fatalities. Early thus means before the fifth day of clinical progress. Number two, doxy should be initiated empirically, that is, based on clinical manifestations, and a negative result in any test does not rule out the diagnosis. And number three, doxycycline is an antibiotic of choice for all ages, including children less than 10 years and pregnant women. Here, I just give you a, a, a resuming of the dosage of doxycycline for children and adults. We need to know that in some patients that have documented allergy to tetracyclines, the alternative is chloramphenicol. Other broad spectrum antibiotics are not non-effective, like sulfa drugs, fluoroquinolones, and cephalosporin can cause more severe disease. If a patient is ill enough to be hospitalized, you need to consider the administration of a single initial loading dose of intravenous doxycycline. So I want to emphasize the importance to take into account four specific considerations for caring of severely ill patients. Number one, we need to be very careful about the management of liquids for intravascular fluid repletion. We need to provide careful inotropic support. We need to provide intravenous administration of doxycycline. And finally, provide mechanical ventilation if there is a significant neurological compromise. This is important because there are evidence that when not properly administered, the replacement of fluids can be very dangerous for patients having the disease. So I'm gonna finish with showing some pictures about the sequela in patients surviving to critical condition of RMSF. So most of you know that in survivors, some dramatic clinical sequela can appear, like amputations, and most of them are other important are neurological deficits. We don't know for sure what is the proportion of sequela. And we, as a physician, don't know precisely the mechanism of sequela, but we know that there are many of patients have 50 to 20% of patients can have sequela in survival patients, specifically neurologically. And I want to conclude saying that, highlighting that, number one, RMSF is the most severe among the rickettsial diseases, as can be fatal in a high proportion of patients that when they are not treated correctly. In spite of that, fatal outcomes of this disease can be averted by the early suspicion and the timely treatment with the specific antibiotic, as I mentioned, is the doxycycline. Number three, the suspicion of RMSF must be made empirically and can be confirmed later using diagnostic tests. RMSF is a public health problem and may be a neglected disease in several regions in the Americas, which affects disproportionately to vulnerable individuals and communities. And finally, you can suspect RMSF in a febrile patient with a history of tick exposure and or being in contact with infested dogs. So I want to finish this presentation just giving my appreciation to your tolerance, your patience, and of course to the invitations from the NCFH. And it was very challenging for me, this presentation, and I'm happy to answer questions if we have time. Thank you, Alexis. Thank you very much to all of you.